Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Symptomatic Toxicities Experienced During Anti-Cancer Treatment, Comparison Between Patient and Physician Reporting in 3 Randomized Trials by Massimo De Maio et al. My name is Claire Snyder, and I am Associate Professor of Medicine, Oncology, and Health Policy and Management at the Johns Hopkins Schools of Medicine and Public Health in Baltimore, Maryland. I am Director of the Program for Building Lifestyle, Outcomes, and Care Services Research in Cancer at Johns Hopkins and President-elect of the International Society for Quality of Life Research. I am a PhD Outcomes and Health Services researcher. In their study, De Maio and colleagues used data from 3 randomized controlled trials with a total of 1,090 patients to compare the toxicity reports of clinicians using the National Cancer Institute's toxicity criteria to patients' reports using validated health-related quality of life measures developed by the EORTC. Both the clinician and patient-reported forms included anorexia, nausea, vomiting, constipation, diarrhea, and hair loss, which enabled this comparison. The investigators found that, compared to the patient's reports, clinicians underreported symptoms ranging from 41% of the time for nausea to 74% of the time for anorexia. Rates of underreporting by clinicians were lower for patients who reported the most severe symptoms, ranging from 13% for vomiting to 50% for anorexia. This study adds to a body of literature comparing toxicity reporting between patients and clinicians. This literature, in general, suggests that clinicians are less likely to report toxicities than patients, with somewhat better agreement for observable toxicities, such as vomiting, than non-observable ones, such as fatigue. The authors provide several explanations for this difference in reporting rates. For example, even though mild symptoms should have been reported based on the common terminology criteria for adverse events, clinicians may have a higher threshold for symptom reporting and may be less likely to report symptoms that they perceive as related to the disease rather than treatment. Inadequate communication between patients and clinicians about these issues might also contribute to the discrepancy in reports between patients and clinicians. Beyond these reasons for differences between reporting rates for patients and clinicians, it is important to note that patients and clinicians bring different perspectives. While clinicians can evaluate patients' toxicities in the context of the range experienced by patients across their practice, patients are best positioned to report their personal experiences of symptoms. Other studies have also demonstrated the differences in perspectives between patients and clinicians. A 2009 study by Bash and colleagues found that patients' symptom reports were more closely associated with their overall functioning and well-being, whereas the clinicians' reports were more closely associated with outcomes such as death and emergency department visits. Similarly, Quinton and colleagues in 2011 found that the ratings from both patient and clinician toxicity reports contributed independent information in predicting survival. Thus, it is more appropriate to see the 2 perspectives as complementary, rather than deeming one perspective as better or more accurate. In fact, the authors of the present study recommend having patients report their symptomatic toxicity directly, perhaps using an electronic system, and making those results available to their providers to inform the clinician's toxicity reporting. Notably, toxicity is just one of an array of patient-reported outcomes. PRO is an umbrella term that refers to any report about health, disease, or treatment reported directly from patients without amendment or interpretation by a clinician or anyone else. PROs include not only symptoms and toxicities, but also outcomes such as functioning, well-being, and health-related quality of life. As demonstrated by this and other studies, PROs contribute unique information supporting their routine collection in both research and practice. Fortunately, a number of tools have been developed by the International Society for Quality of Life Research and others to aid in the collection and use of toxicity and other patient-reported outcomes. In terms of collecting toxicity reports from patients, DeMaio et al. Note that a patient-reported version of the CTCAE has been developed. Specifically, Ethan Bash and colleagues, in collaboration with the U.S. National Cancer Institute, identified the items of the CTCAE that were appropriate for patient self-report and adapted the grading scale to lay terms. They also developed an electronic system for administering the scale. More information about the PRO-CTCAE can be found on the NCI website. Tools are also available for publishing the PRO findings, including an extension to the Consolidated Standards of Reporting Trials developed specifically for PROs. This Consort PRO extension, published by Melanie Calvert and colleagues in JAMA in 2013, provides specific guidance on appropriate information to include in publications of randomized clinical trials where PROs were an outcome. Work is currently underway to develop guidance for protocol writers interested in including PROs in their studies. PROs also provide important information for consumers of the medical literature, and Albert Wu and colleagues published a clinician's checklist for reading and using an article about patient-reported outcomes in the Mayo Clinic Proceedings in 2014. This reader's guide provides a series of questions that clinicians can use to evaluate studies reporting PRO data. Aside from the role of PROs as an outcome in research studies, there is increasing interest in implementing routine assessment of PROs in clinical practice to inform individual patient management. DeMaio and colleagues suggested direct reporting of toxicities by patients participating in clinical trials, but PRO assessment need not be limited to the research setting. The communication obstacles noted previously also apply in routine care, and a number of studies investigating the use of PROs in clinical practice have demonstrated its effectiveness in promoting patient-clinician communication. To support such efforts, ISAQOL developed the User's Guide to Implementing PROs in Clinical Practice, which is available on the ISAQOL website. This User's Guide goes step by step through the considerations and options for implementing a PRO intervention in clinical care, thus providing guidance to practices interested in implementing routine PRO assessment. The importance of this study's finding of differences in patient and clinician reporting of toxicities is not that one perspective is more accurate or in some way better than the other, but that the two perspectives provide complementary information. A number of tools are available to facilitate integrating the patient voice in research and practice. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.